endocrine function and neural plasticity. And there are many studies that support this theory that inflammation is associated with depression. So here was a study of 50 non-medicated major depressive disorder patients. And you can see that all of these cytokines, inflammatory cytokines, were elevated at the beginning of the trial. And after 12 weeks of treatment, 7 of the 9 had decreased. The authors state recovery from depression was associated with a reduction to normal levels of the majority of the measured cytokines. These results strongly support the notion that a complex network of cytokines is involved in the pathophysiology of major depressive disorder. Another study looking at C-reactive protein. Serum HS-CRP is an independent risk marker for de novo major depressive disorder in women, which supports an etiological role for inflammatory activity in the pathophysiology of depression. But what is the etiology between this association between inflammation and depression? Perhaps their effect on neurotransmission, because once cytokine signals reach the brain, they have the capacity to influence the synthesis, release, and reuptake of neurotransmitters like serotonin, dopamine, and norepinephrine. And the influence of inflammation can be bidirectional, systemic in the body, manifesting in peripheral symptoms. So our learning objectives today will be to examine some of the common etiologies of inflammation, discuss testing considerations, and then we will end by discussing a patient of mine that was particularly challenging and helped me learn a lot. So cytokines, they are signaling molecules that are made by cells, right? They're essentially the way that cells communicate. All cytokines either promote inflammation like these. You can see IL-6, TNF-alpha. These are very commonly seen pro-inflammatory cytokines. Or cytokines can help to bring the inflammatory response to an end. Cytokines like IL-10 are considered to be anti-inflammatory. Perhaps the most important thing to try to figure out when you're dealing with inflammation is determining the source of the inflammation in a particular patient. This is the most important aspect of today's lecture, and this study gives us a lot to consider. So the actual name of the study is, so depression is an inflammatory disease, but where does the inflammation come from? So the authors state, we now know that depression is associated with a chronic, low-grade inflammatory response and activation of cell-mediated immunity, as well as activation of the compensatory anti-inflammatory reflex system. A range of factors appear to increase the risk for development of depression and seem to be associated with systemic inflammation. These include psychosocial stressors, poor diet, physical inactivity, obesity, smoking, altered gut permeability, atopy, dental caries, sleep, and vitamin D deficiency. The identification of known sources of inflammation provides support for inflammation as a mediating pathway to both risk and neuroprogression in depression. Critically, most of these factors are plastic and potentially amenable to therapeutic and preventative interventions. This article has really helped to guide me into the areas that I have begun asking about when I take a history. So today, I wanted to walk you through some of the factors that can result in chronic inflammation. These are really important because if you suspect chronic inflammation in a patient, finding the source can be really tricky. And maybe today I'll touch on something that you haven't considered before. But diet is a pretty obvious one. We all know that our patients should be avoiding sugar, bad fats, conventionally raised meat, which essentially is due to the bad fats, too much alcohol, refined grains, additives, and then any foods that they're allergic to. You should be considering the activity level of your patients. This probably seems like a no-brainer, but studies back up the importance of exercise in lowering inflammatory markers. Obesity. This is a big one. We know that obesity can lead to inflammatory conditions, but also that inflammatory conditions can lead to obesity. And obese, insulin-resistant adipose tissue actually promotes inflammation by secreting pro-inflammatory cytokines. So you can see here the difference between healthy adipose tissue and obese insulin-resistant adipose tissue is that the macrophages in this type of tissue actually secrete all of these pro-inflammatory cytokines. Smoking, again, a no-brainer, right? But we know that smoking contributes to inflammation at mucosal surfaces, which changes the way that the host responds to antigens. And remember, this can apply to all types of smoking, including cannabis. If you suspect inflammation, do you think to ask about dental health? This is something that I was routinely overlooking, but we shouldn't, because a lot of people don't have dental insurance and they may be neglecting dental issues due to financial constraints. Outside of that, a lot of people are just scared of the dentist and they don't go. But keep it in mind, because you can see here that the presence of cavities increased pro-inflammatory cytokines and also periodontitis. Altered gut permeability must be considered, because as long as there is a leaky gut, inflammation will be constant. More and more research is showing us the importance of the microbiome in relation to a whole host of pathologies. So this study looked at MS, which is an inflammatory condition, and this is really meaty, so I'm going to read this slide. Researchers found that 2 bacterial groups, Acinetobacter and Akkermansia, were 4 times more abundant in MS patients than in individuals with no disease. Another group, Parabacteroides, was 4 times as abundant in healthy people. The researchers then took naive immune cells from the blood of healthy individuals and exposed them to bacteria in the gut of MS patients. In the presence of Acinetobacter and Akkermansia, they became a particular type of T helper cell, which triggers inflammation. Acinetobacter also ramped down the production of regulatory T cells, which help prevent autoimmune disease by dampening the immune response. The researchers observed similar differences when they transferred the MS gut bacteria to germ-free mice and induced brain inflammation. Within 20 days, the mouse receiving gut bacteria from MS donors developed severe brain inflammation. But when gut bacteria from the control group were transferred to the mice, they did not get sick. You're sleuthing, you haven't found anything yet. What about hidden infections, right? You might want to do some testing to determine if there may be a virus or maybe a tick-borne illness or some sort of an atypical bacteria present. And if you can't find a source of infection, consider mold or potentially other exposures in the home or in the workplace. Are your patients sleeping? We know that insomnia alters cytokine expression, and we will see more pro-inflammatory cytokines when people don't get enough sleep. Insomnia also affects glucose metabolism. In this study, a lack of sleep led to decreased glucose tolerance, decreased insulin sensitivity, and increased glucose production. And these changes were seen with as little as 3 nights of disrupted sleep. Don't forget about vitamin D deficiency. So this trial looked at certain inflammatory diseases and their relationship to vitamin D. So they stated patients with chronic inflammatory diseases such as asthma, arthritis, and prostate cancer who are vitamin D deficient may benefit from vitamin D supplementation to get their serum vitamin D levels above 30 nanograms per mil. So you can see when they incubated cells with no vitamin D up to a solution containing about 15 nanograms per mil, they saw high levels of inflammatory cytokines. But as they increased the amount of vitamin D all the way up to 50 nanograms per mil, they saw inhibition of these pro-inflammatory cytokines. So protection began at about 30 and topped out in the study at about 50. Hormone imbalance is also something that's very important to consider, especially the androgens. We know that obesity and insulin resistance are inflammatory conditions, and these issues can result in hormone changes in androgens. What we see is elevated testosterone and DHEA in females, and then in males, we see low testosterone in response to insulin resistance, sometimes low DHEA as well. So if you see these types of shifts in hormone levels, it's wise to look for an inflammatory process like insulin resistance or metabolic syndrome that may be driving it. We've probably all observed this, but research confirms that autoimmune and inflammatory disease is expressed in a disproportionately higher incidence in females compared with males, which indicates a role for sex hormones in disease susceptibility or progression. I have found progesterone to be a very effective tool in managing inflammation in my patients, and there is a lot of research that supports its use. Cortisol is the most important endogenous glucocorticoid. It responds to inflammatory and to stressful types of stimuli. This led to the development of pharmacological glucocorticoids, which are much more potent than cortisol. But I do want to emphasize the differences in the way the body responds to pharmacologic versus physiologic potencies of glucocorticoids. You get a very different response to the same substance when different potencies are used. We know that essentially when we're looking at steroid levels, these powerful pharmacologic doses of glucocorticoids, they act as immunosuppressants. However, at physiological concentrations, glucocorticoids are more immune modulating, meaning they can increase cortisol when it is low. You know, in some cases, pharmaceutical doses of steroids are a lifesaver, and there's nothing that can suppress inflammation as well as they can. However, this type of immune suppression can be dangerous in the long term. So it may be that physiological dosing is a better option for actual repair of the HPA axis and for longer term support for various inflammatory conditions. While balancing hormones is often an appropriate strategy for managing inflammation, we can actually cause iatrogenic inflammation because of the route of administration of hormone replacement therapy. So this study looked at postmenopausal women, and they found that oral but not transdermal estrogen therapy increased CRP, C-reactive protein, by a first-pass hepatic effect. An increase in CRP levels is accompanied by a reduction in IGF-1 and anti-inflammatory growth factor. So I do want to emphasize again, oral estrogen therapy was shown to increase inflammation. Transdermal estrogen therapy will not. So if you feel like estrogen therapy is appropriate, that's fantastic. It can be a potent anti-inflammatory, but make sure that oral administration is not your choice for your patient. This rodent study helps to illustrate the differences in the ways that the body will respond to acute versus chronic inflammation. So they exposed these little guys to lipopolysaccharides, which are inflammatory. And so the acute response to the LPS was that HPA axis was stimulated. You can see cortisol levels actually increased in response to acute infection. But chronically, this chronic exposure to LPS actually desensitized the HPA axis response. And you saw this blunting of cortisol. When we think about the concept of stress and the immune response, it's important to consider psychosocial stress. The source of inflammation can be clear when depression occurs in the context of medical illness where there is an infectious, autoimmune, or inflammatory component, or when there's tissue damage or destruction, all of which are associated with activation of peripheral and in some cases central inflammatory responses. However, in the case of presumably medically healthy, depressed individuals, the source of inflammation is less apparent. A major breakthrough has been the increasing recognition that psychosocial stress can activate the inflammatory response both peripherally and in the brain. And any type of stress can result in inflammation. This study looked at stressors in the form of public speaking and mental arithmetic stressors. And they found that these types of stressors cause increases in the pro-inflammatory cytokines, NF-kappa B and IL-6. But you can see here at this bottom bullet point that things like caregiving or marital discord, perceived stress, these can also cause increases in pro-inflammatory cytokines. The shallow breathing that we typically see with stress can lead to a lack of vagus nerve stimulation. Remember that the vagus nerve is parasympathetic, and so when vagus activity is decreased or absent, we can see an increase in inflammatory cytokines. Ways to engage the vagus nerve are deep belly breathing, mindfulness, even by improving our gut flora. These are all ways to engage vagus nerve activity. So in addition to taking a thorough history, which provides subjective information, it's essential to do some testing to gather objective data in our patients. So you might consider testing C-reactive protein or high sensitivity C-reactive protein. So a CRP test doesn't indicate the cause of inflammation, though. It just tells us if inflammation is present. High sensitivity CRP is a potential consideration when you're looking for sort of that subclinical inflammatory process. I do want to note, though, that the American Heart Association doesn't recommend HSCRP testing for everybody, generally only people who are at significant risk for heart attack. But I believe it's possible that an HSCRP level could mean that there's inflammation caused by something besides your heart. I look at it as just a more sensitive way to assess inflammation in a general way. And an ESR, serum amyloid A, or testing for white blood cell increases. These are additional ways to screen for the presence of inflammation. But again, they're not going to point to the source. For that, functional testing can be very helpful. Doctor's Data offers gluten sensitivity testing, which I rely on quite frequently. The current estimated prevalence of celiac disease is about 1% in the general population in Europe and in the United States. But it's estimated that the prevalence of gluten sensitivity is actually between 3 and 6%. And I find that this incidence is actually a little bit higher in the patients who find their way to me. The people who find their way to functional medicine providers have often exhausted a lot of the conventional resources. And so you may find that the incidence of gluten sensitivity in your patient population is a little bit higher than what those national norms might indicate. As I stated earlier, a leaky gut essentially ensures inflammation. So zonulin testing can be very helpful because it's a marker of intestinal permeability. High levels of zonulin have been associated with increased intestinal permeability because it induces the breakdown of the tight junctions between intestinal epithelial cells. Testing for the microbiome, the makeup of the microbiome, can be so helpful. So this is the GI360 microbiome profile. So it's a gut microbiota DNA analysis tool that identifies and characterizes more than 45 targeted analytes across 6 phyla. You can see those here. Using PCR, and it compares your patient's results with a characterized normobiotic reference population. So the abundance and diversity of gastrointestinal bacteria provides an indication of gastrointestinal health, and gut microbial imbalances can contribute to dysbiosis and other chronic disease states. The web chart here indicates the individual's microbiome profile and how it deviates from normobiosis. So the normobiosis here is the stark green area. If the web pulls out to the red, that indicates an overabundance, and if it pulls into what's a blue area in here, that would be an underabundance. Then we have the dysbiosis index score, which is calculated strictly from the results of the microbiome profile, and the scores range from 1 to 5. So a dysbiosis index score above 2 is going to indicate dysbiosis, which is a microbiota profile that differs from the defined normobiotic reference population. The higher the DI is above 2, the more the sample deviates from the normobiotic profile. And then pathogenic bacteria, yeast, parasites, viruses, et cetera, are also reported as part of this profile, and so are stool chemistries and beta-glucuronidase. Comprehensive hormone profiles can test estradiol, progesterone, testosterone, DHEA, and 4 cortisols. You can also add additional estrogens to this testing. You can add additional cortisols to get a cortisol awakening response. There are a lot of options. But it can be important to do this testing because we understand the limitation to do it. If we can convince our patients to eat an anti-inflammatory high-fiber diet, begin an exercise program, incorporate stress reduction, get to a healthy body weight, and get consistently good sleep, they will be well on their way to avoiding those inflammatory conditions. But, and this is crucial, whenever possible, you have to try to identify and treat the source of the inflammation. So to illustrate how these tests can help to guide your treatment approach, I wanted to introduce you to Molly. This was a tough case for me, and the testing that we did together was essential in helping me figure out how to best help Molly. So Molly's a 53-year-old female. She's the mother of 3 children, 1 grown up, 1 in college, and 1 a senior in high school. She's postmenopausal, 5'7", weight at 202, which puts her into the BMI of obese at 31.6. She eats a standard American diet, doesn't exercise, and has a history of depression. She has rotated through antidepressants over the years, with none having much of an effect. She's currently taking fluoxetine at 40 milligrams a day. She says that she's soon to have an empty nest, and so she wants to begin focusing more on herself. Maybe you have heard that too. That's something that I do hear commonly with women at about this point in their lives. So Molly reports weight gain. She officially became menopausal 2 years ago and has gained 35 pounds since then. Hot flashes are frequent throughout the day, at least 1 per hour. She has insomnia. Sometimes she has trouble getting to sleep, but she always has trouble staying asleep. She reports not feeling well rested in the morning and also having severe fatigue in the afternoon and evening. Her cognitive function has declined in recent years. She's now reporting trouble with memory and focus. She says she's depressed. And again, this is sort of self-reported feelings of sadness, but she had been on an antidepressant for years. Also anxiety and irritability, a poor libido, gas and bloating, alternating constipation and diarrhea. She says she's associated an increase in those symptoms when she eats sugar. She also has ankylosing spondylitis, which causes her back pain. And you can see here at the bottom, all of these symptoms she marked as severe on a symptom questionnaire that I gave her. The symptoms that really stand out to me after I met Molly is being her chief concerns for the hot flashes, the insomnia, the fatigue, the cognitive concerns, the depression, the anxiety, and the poor libido. So this felt like a neuroendocrine type imbalance to me, and so I started with hormone and neurotransmitter testing. So these are Molly's results. You can see here progesterone is low, which is consistent with a postmenopausal female. That equals a low progesterone to estradiol ratio, which is essentially what we call estrogen dominance. You can see here there's no reference range for this ratio unless she's supplementing, and that's because this is a clinical ratio, not a physiological one. It's based on the work of John Lee, MD. So in postmenopausal women who don't get there because they're no longer ovulating, you want to look at this information, but realize she won't reach greater than 200 unless supplementation is implemented. But I view this as estrogen dominance, which I would have anticipated in a postmenopausal woman because she's no longer ovulating. We also see these elevated androgens here, which suggests to me dysglycemia, insulin resistance, potentially metabolic syndrome. Also, we see HPA axis dysfunction, what we consider phase 3. This is a pretty flat line here, what should be a nice, beautiful, gentle, sort of downhill motion here. This dark green area would be considered optimal. She is pretty flat, so this is phase 3. So I know that progesterone insufficiency can be associated with inflammation. There are some studies out there that actually indicate elevated testosterone has been associated with depression. So that's something to keep in mind because of her issues with depression over the years, but also the metabolic changes that can result in elevated androgens. And then we've already discussed some of the effects of stress on inflammation, and we see a phase 3 HPA axis dysfunction here. So this is highlighting a lot of areas that we can focus on to potentially help with the inflammation that could be present. Molly's imbalances that we found with neurotransmitter testing are in line with her reported symptoms. So you can see low range serotonin and low dopamine are associated with mood concerns, decreased cognitive abilities, and cravings. Upper range norepinephrine and epinephrine are associated with anxiety, agitation, irritability, insomnia, and lack of mental focus. Upper range glutamate may contribute to anxiety, poor concentration, and attention deficits, and nighttime waking. Low GABA can be associated with anxiety and decreased sleep quality. Low histamine may affect learning, memory, and mood. And low PEA, phenethylamine, is associated with cognitive concerns. The elevated epinephrine and norepinephrine here also indicate, to my way of thinking, a more advanced phase of the stress response. So remember, if we look back here at the cortisol, this is very, very depleted. And here, if we look at epinephrine and norepinephrine, we can see they're towards the top of the range here. So this is something that I see frequently when cortisol begins to decline, is that, the body is still having to respond to stress. So when cortisol is unable, because through adaptation and depletion, that HPA axis is not responding to stress in the way that maybe is more appropriate, we might see the stress catecholamines, epinephrine and norepinephrine, be elevated as a way to continue to allow the body to respond to stress. This is sort of an adaptation. These catecholamines are holding on, trying to compensate for cortisol not being able to perform adequately. So this is something that I see quite frequently. I also tested Molly's melatonin. We know that serotonin is a precursor to melatonin, and her serotonin was low. So that's pretty consistent with the melatonin pattern like what we see here. Molly reported that she sometimes has trouble getting to sleep, but always has trouble staying asleep, and she certainly is not making much melatonin. So that certainly could be contributing to insomnia. And then when people don't sleep, that promotes inflammation. Molly has an MD who's acting as her PCP, and so this information on lipids and things came from labs that she ordered. So just a summary here, her BP is a little bit high. When it comes to lipids, trigs are a little high, LDL a little high, HDL a little low. Hemoglobin A1C suggests, to my way of thinking, prediabetes, and so does the fasting glucose. Her vitamin D is suboptimal. So essentially, because of what we see here, BP a little high, lipids and glucose levels suboptimal, we have a case of metabolic syndrome. And then, of course, the elevated androgens that we saw in hormone testing also support this diagnosis. So this is what I now am thinking are obstacles to cure for Molly. Inflammation. How can I say she's inflamed? She's obese. She has GI distress. She has hormone imbalance. She's not getting restorative sleep. She has blood sugar imbalance. She eats a pretty crappy diet. She reports stress. Her HPA axis is compromised. She's vitamin D insufficient. I'm suspecting metabolic syndrome because of the blood pressure and lipids that were found. A waist circumference also of 38 inches is what she had at this point. I'm also suggesting food sensitivity issues here because she's eating a standard American diet and she's reporting constipation and diarrhea. So I think that should be considered. And also, the pain and inflammation from her ankylosing spondylitis is probably also a significant stressor. So therapeutically, what I like to do to address estrogen dominance in postmenopausal women is progesterone supplementation, because once ovulation has stopped, the body no longer is able to secrete adequate amounts of progesterone. So 30 milligrams twice a day is what I chose to do. When hot flashes or night sweats are present, giving progesterone twice a day is a good strategy because it keeps hormone levels a little bit more steady over a 24-hour period. Sometimes it's fluctuation in hormone levels rather than high or low hormone levels themselves that can cause those vasomotor symptoms. So twice a day dosing is a good little pearl when you've got those vasomotor symptoms. To address the elevated androgens, I recommended a low-carb, protein-forward diet, sort of a paleo style. Molly, because she's a carnivore, said she really wanted to focus on sort of a meat-heavy diet, so I told her that was fine. And she also chose, I chose these nutrients, C, chromium, NAC, and cinnamon to help her with blood sugar regulation. And then to address her impaired stress response, we gave her an adaptogenic formulation with these great adaptogenic herbs in it, as well as some good vitamins and hydrocortisone. 10 milligrams in the morning and 5 at noon. So if you're unfamiliar with using hydrocortisone to treat impaired HPA axis function, remember that if you don't give more than 20 milligrams per day, you're very unlikely to suppress endogenous cortisol secretion. And so 10 in the morning and 5 at noon is well within that safe window. I generally give adaptogenic support, nutrient support at the same time as I'm giving hydrocortisone. The way I explain it to my patients is I'll say, okay, pretend your adrenal glands are playing a basketball game and they've played so hard that they're now incredibly fatigued and they need to come take a break and sit on the bench. So the adrenals come and sit on the bench and hydrocortisone goes in to play for them. While the adrenals are on the bench, resting and drinking their Gatorade, that Gatorade actually is made of adaptogens and nutrients. Once the adrenal gland feels energetic again, the hydrocortisone comes out and the adrenal gland is able to go back in and play the basketball game. So it's kind of a silly analogy, but I think it helps my patients understand that what I'm trying to do is rebuild adrenal function. The hydrocortisone allows them to have a little bit of energy, which helps them be motivated and maybe compliant with the things I'm asking them to do, while I'm also trying to rebuild that HPA axis functionality with the adaptogens and nutrients. When it comes to neurotransmitter treatment, the imbalances that we found, I always utilize a B complex with activated forms, and that's because B vitamins are important cofactors throughout the biochemistry of neurotransmitters and neurosecretion. Theanine is a wonderful addition to any neurotransmitter balancing protocol because it's modulatory. We sort of think of it as the adaptogen for this system. So when things are either too low or too high, theanine can help sort of bring them back to midline. An anxiolytic herbal tincture to help with all that anxiety and irritability that she's feeling. And anxiolytic tinctures can also often help to buffer these types of elevations. So norepinephrine, epinephrine, and glutamate are all excitatory and they're all elevated, and that can cause a lot of problems. 5-HTP to support the serotonin, and then phenylalanine will support dopamine as well as PEA because it's sort of the mother hormone or the mother amino acid, for that catecholamine pathway. GABA, because GABA is low here, and we want to try to provide some counterbalance, some parasympathetic activity to counterbalance all of this excitability. So that's where the GABA comes in. And of course, L-histidine to support the histamine. So some of the other treatments that I implemented was melatonin, 1 milligram immediate release and 2 milligrams slow release at bedtime. I added the slow release melatonin because Molly was having trouble staying asleep. So I will often combine an immediate release and a slow release in these cases because melatonin has a short half-life of about 30 to 60 minutes that in the immediate release form, but the slow release form can actually last for 5 or 6 hours. Vitamin D because she was vitamin D deficient. Probiotics just sort of as a matter of course. Fish oil because omegas are so anti-inflammatory. That low carb diet we already discussed because of the insulin resistance we think is at play. I recommended exercising at least 30 minutes, 5 days a week, and trying to implement mindfulness. And I'll often recommend some of the great apps that are out there to help people with mindfulness. I think it can be really overwhelming to tell somebody, all right, for 3 minutes a day, I need you to stop and calm your mind and just breathe deeply. Sometimes that very simple request is really overwhelming. But these apps can provide some guidance to help people slow down and do that. So those are a great tool. The exercise, because she has ankylosing spondylitis, remember that movement's really important because we want to make sure these patients avoid vertebral fusion. So I was encouraging Molly to do cardio as well as trying to do some stretching and some yoga to try to keep her joints mobile. A quick note about exercise, people quite often view exercise as punishment. I don't know if this comes from being in school and being told to run laps when you were late, I don't know, but whatever the reason, it's our challenge to try to help patients see the fun in exercise. There's so many fun ways that people can move their bodies. So we just have to try to help them find out what it is that motivates them, what's fun for them. Okay, so the fluoxetine weaning, it was Molly's decision to try to wean off the fluoxetine. She didn't feel like it was working and she wanted to try to get a handle on her depression in other ways. So you recall, recommended 5-HTP to Molly. Her serotonin was low. And I want to touch on this. I did recommend 5-HTP even though she was taking an SSRI. In this case, I view 5-HTP as safe because her serotonin is on the low end. So I'm not concerned about serotonin syndrome. In my view, giving 5-HTP is likely going to make this weaning process easier. I would never do this unless I tested first to ensure that the serotonin was not elevated. If serotonin were elevated, I wouldn't want to give 5-HTP if she were using an SSRI for fear of causing serotonin syndrome. But in this case, I felt like it was a safe option. And you can see Molly did really well for a while. So my protocol with weaning is for the first week, you do a full dose alternating with the reduced dose on alternating days. And so then on the second week, you go to the reduced dose all days. Week 3, you reduce the dose again, but alternate it with the week 2 dose. And then for week 4, you go to the week 3 dose every day, et cetera, et cetera. So you can see Molly did really, really well until we got to week 6. When she got to 10 milligrams, she got stuck here. For many, many months, we were both frustrated. More to come on that. Okay, 6-month follow-up. So I check in with Molly. She says some of her symptoms have improved, but she's still having mood concerns, sleep issues, gas and bloating, cognitive concerns, which was frustrating for me because you can see here, as far as labs go, things look really great. Her progesterone now is beautifully balanced. When it comes to androgens, you can see testosterone has dropped from 58 to 51, still elevated, but moving in the right direction. And DHEA now is within the reference range. And when it comes to cortisol, this sort of what we call a flat curve, or lack of one, we're starting to see some curving. This AM value in particular, which should be the highest of the day, is looking really nice. This looks great, but these symptoms persist. So we did some neurotransmitter testing as well, and these results were not so great. So you can see here, there was some positive change, I guess. We had these upper range catecholamines and glutamate that now have come down. So the norepi and epi are now low, as is glutamate now, not low, but trending towards the bottom of the range. But none of these low levels have improved at all. So what's going on, and why did we see improvement with hormone testing, but we don't see improvement here? So, I think maybe it's because the hormones that I gave her were largely transdermal, and so they were avoiding the gut and first pass, and so she was absorbing those. She was also making some dietary changes, some lifestyle changes with exercise, some mindfulness, things that can really improve HPA axis function and cause these catecholamines to come down. The dietary changes she was making, the standard American diet often has foods that are high in glutamate or glutamic acid because that's a flavor enhancer that's added to a lot of foods to improve their flavor. We're probably all familiar with monosodium glutamate. So now that she's making better dietary choices, the glutamate has come down. But the things I was trying to support with supplementation, serotonin, the dopamine, et cetera, those have not changed very much. So now I'm thinking there's probably something significant going on in her gut that I need to look into, right? She's probably not absorbing all of these great supplements. So I decided then to do a GI 360 test on Molly. So you can see here the abundance and diversity here of her gastrointestinal bacteria did give us some insight. So again, what this web chart does is try to show us the degree to which our patient's microbiome deviates from normobiosis. So the normobiosis, again, is this green area. So Molly had too few of the Firmicutes and too many Bacteroides, Proteo, et cetera. So that is not ideal. And then this dysbiosis index score of 3 is also not great. Remember, anything above a 2 indicates dysbiosis. a profile that differs from this normobiotic reference population. And you can see here, loose, watery, soft stool. Molly also had some interesting findings in the sort of bacteria yeast area. We look here at fecal pH. We know that pH in the stool is largely dependent on the fermentation of fiber by all the beneficial flora in the gut. So if we have a low pH like Molly, it's likely due to dysbiosis. Klebsiella is a normal finding, but it's considered dysbiotic if it's at +3 or +4 growth. Overgrowth can cause gas and bloating, and interestingly, is associated with ankylosing spondylitis. Patients with ankylosing spondylitis usually have larger amounts of Klebsiella than their non-ankylosing spondylitis counterparts. So that was a very interesting finding. The worsening of the diarrhea and bloating with ingestion of sugar is consistent with the finding of 3 strains of Candida here. Molly also has a parasite, Dientamoeba fragilis. I found out that this parasite is actually pretty common. It infects the large intestine, can be spread via pinworm eggs. So with parasites and overgrowth like these, we would expect secretory IgA to be elevated, but in fact here we see that it's low. It's no longer responding to the infection, which indicates to me this infection's probably been there for quite some time, and so the body's secretory IgA has been depleted. So, you know, we know that if all of this, especially the parasite, is left untreated, we can see a lot of damage to the intestinal lining, which is a cause, and all of this really is a cause of inflammation, right? And potentially contributing to her fatigue and all the ways she's feeling pretty crummy. One of the cool things about this test is that they provide susceptibility testing to guide us and how to choose the right therapeutics for each individual patient. So in Molly, you can see that berberine and black walnut would not be indicated to address the Klebsiella, nor would ampicillin. And for the 3 strains of Candida, what you want to do is try to look at if any of these high susceptibility herbs or antifungals are repeated between strains, and that might be your best option. So generally what you would want to choose is maybe 1 to 2 of the top natural agents or 1 prescription agent as therapy. So you can see for Molly, the best azole would be ketoconazole, because that is susceptible in all of the strains. Nystatin is a good choice across the board. For the more natural therapies, grapefruit seed extract is the agent that all 3 strains were susceptible to, with a possible second option of being caprylic acid. So not quite as great here. So here is what I landed on. So for the Dientamoeba fragilis, the standard of care is to use iodoquinol, 650 milligrams 3 times a day for 20 days. The side effects of iodoquinol can be pretty brutal: gas, bloating, and stomach upset, and rectal itching and irritation. Those may make sense, but also blurred vision, which is kind of a scary one. Molly actually did experience stomach upset, rectal itching, and eye blurriness, but she soldiered through and completed the course. For the yeast and Klebsiella, we used grapefruit seed extract because that was a good option across all of the susceptibility testing. A standard American diet can make imbalanced flora worse. So can protein-forward paleo diets, because they don't contain a lot of fiber for the microbiota to feast on. And so Molly had been doing really well with her paleo style diet, but she'd been on this diet for a while. She'd lost some weight. And so at this point, I counseled her to start adding in more fiber, specifically soluble fiber, to improve the microbiome. We also discussed pivoting more to a Mediterranean style diet, which would still be low in sugar and simple carbs, but filled with good veggies and fats. And you can see for secretory IgA, you want to add in AD and zinc. So I decided at this point it was important to do some gluten sensitivity testing for Molly. She had mostly been avoiding grains with the paleo diet, but she had still been eating some gluten. And because at this point I was asking her to introduce more grains, I thought it was appropriate to test for gluten sensitivity, because I find that issues with gluten are really common in my patient population, but also with autoimmune disease and with the ankylosing spondylitis. That makes Molly a candidate. So this was her test, and this test is actually really easy to read. So you can see here the key is the deaminated gliadin peptide, IgA and IgG antibodies. So these two, if either is positive, consider celiac disease. Neither was positive for Molly, so we go to negative and we look at the gliadin, IgA, IgG, and gluten IgG antibodies. Here you can see she's positive and weakly positive for all three, so consider gluten sensitivity. So this leads me to believe that Molly should be avoiding gluten. Do remember that if you have patients who have been avoiding gluten exclusively, they're going to have to eat it for this test to be accurate, so it may not be an appropriate test. And people who just avoid gluten because they suspect they may be sensitive to it, you have to actually be eating the gluten to get this type of immune response to it. But this test did indicate that Molly would do well to eliminate it, so I recommended that she avoid it. So after all of those interventions, we retested 12 months later, and you can see that we're finally getting somewhere. Molly's feeling a lot better. Her GI retest looks so much better. Abundance is better. I decided, I'm telling her we need to continue to stress fiber in the form of legumes and fruits and veggies, but we can see now this webbing looks really beautiful. The dysbiosis index score is 1, which means the gut is now pretty normobiotic. The pH and the secretory IgA are now within normal limits. Parasite's gone, the yeast is gone, the Klebsiella is gone, so they didn't report that. So 12 months after I started working with Molly, she's lost 30 pounds. Her BMI is now 25.8, which is just into the overweight category. She's almost into that normal BMI, which is a goal of hers. Hot flashes are better. She's sleeping a little bit better. Fatigue is better. Cognition is better. She's less anxious, less irritable. Libido is better. Vitamin D levels are coming up. Alternating constipation and diarrhea, much better. Now she's got well-formed stools, and gas and bloating are nearly gone. But perhaps the biggest success for both Molly and me was she was finally able to discontinue the fluoxetine. And I didn't write this down, but great for Molly, she had also been experiencing less discomfort in her back and her neck from the AS and was having more range of motion, I think largely because inflammation in general was down with Molly. So following up, continue a lot of these good therapeutics, but at this point I felt like I could adjust the vitamin D. Her A1C and fasting glucose looked good. The weight loss and the adherence to the Mediterranean diet led me to discontinue vitamin C, chromium, NAC, and cinnamon. The gut treatments we were able to discontinue at this point, and that anxiolytic tincture she could just use as she felt like she needed it. So that was Molly. She was a great learning experience for me. And she ended up doing really well in the end. And I was really thankful for all of those tests to help guide my treatment choices for her. So, in summary, I just want to say that we really do need to take a thorough history to get that subjective point of view, but also do appropriate functional laboratory testing to try to determine the sources of inflammation. Identifying the source is essential because then we can be targeted in our approaches to controlling inflammation. But these are the types of therapies that it's generally important to consider, because we all want our patients to feel good and to be well.